Hey, good morning, everyone. I actually added a subtitle to my lecture, and the title is To Dream the Impossible Dream. Advancing the limits of aligner treatment with TADS. I tell my patients, the evolution of technology has helped us deliver better clinical outcomes. And today, many of you in the audience would join me to say that we're doing things with orthodontic appliances, with TADS, with MARPs, and with aligners that we never dreamed would be possible 10 or even 20 years ago. My name is Dr. Sandra Khong. I'm a clinical assistant professor at the University of British Columbia in Vancouver, Canada, which is my home city. And I'm also very privileged to be an adjunct assistant professor at the University of the Pacific in San Francisco. I received my orthodontic training at the University of Minnesota, and to date, I've treated over 4,500 lifetime aligner cases. I'm a diplomat of the American Board of Orthodontics. Many of you will also know me as the author of the textbook Clear Aligner Technique, which is available through Quintessence Publishing, but today it's in 12 languages around the world. I've also written Chapter 22 on clear aligner treatment in Graeber's Orthodontics 7th edition. And over COVID, we developed an online resource for any doctor or orthodontist wanting to be systematically trained in clear aligners. This is a conflict of interest disclosure. I am a member of the Align North America Advisory Board and the Align Tech Global Faculty. As an author, I also receive royalties from the English and Spanish translations of Clear Aligner Technique. So let's go today. What are we going to learn? We're going to learn how to integrate TADS with clear aligner treatment where additional anchorage requirements are needed. TADS are not a magic appliance. And essentially, TADS give us the additional anchorage we need when we're planning the biomechanics and anchorage requirements of tooth movement. We're going to learn how to correct a maxillary occlusal cant with clear aligners and TADS, and we're going to learn how we're going to combine anterior-posterior correction protocols with vertical deep bite and open bite protocols augmented with TAD anchorage to correct severe open bites in Class 2 and Class 3 malocclusions. Sometimes in orthodontics, there's nothing new under the sun. Did you know that TADS were actually introduced in 1945? And in this article in the American Journal of Orthodontics and Oral Surgery, Dr. Gainsforth proposed a study of orthodontic anchorage possibilities in basal bone. So essentially, TADS are anchorage points in the basal bone, and today many of us use TADS to augment the anchorage we need to accomplish certain type of tooth movements. In the next half hour, this is what I'm going to talk about. Posterior intrusion in interdisciplinary restorative cases, anterior intrusion for maxillary occlusal cant, whole arch intrusion for excessive gingival display, and finally we'll look at posterior intrusion in a Class 2 open bite and then in a Class 3 open bite case. So let's go. In this first case, you can see on the left-hand side of the screen that the patient has lost their mandibular molars, leading to hypereruption of the maxillary molars and inadequate posterior occlusal clearance. So now that she's ready to proceed with restorative treatment in the lower right quadrant, we need to create that posterior occlusal clearance for her. This is the pre-treatment panoramic radiograph, and you can see the posterior occlusal plane with the hypereruption. Now, when we set up tooth movements in the digital treatment plan, and we look at the tooth movements that come back, and as we look at these tooth movements that are going through there, I think I have one question for you. Where is the anchorage coming from? When we look at a digital software plan that comes back, as an orthodontist, and I look at the type of tooth movements that have been programmed, two questions are running through my mind. Number one, Is this tooth movement biologically possible? We talked about keeping teeth within the housing of alveolar bone. And number two, if this tooth movement is biologically possible, is it clinically predictable? So how do we know? When you use the superimposition tool on the software and you turn on the tooth movement assessment, the software will tell you how difficult or how easy it's going to be moving the tooth, and the software will tell you if this type of tooth movement is within the capability of aligners. So here you can see two black dots on the maxillary first and second molar, and the amount of intrusion for the first molar that's been programmed is 2.14 millimeters, and anything more than 1 millimeter posterior intrusion is going to be an advanced tooth movement. The second molar is programmed for 1.59. Anything more than 1 is going to be an advanced tooth movement. And therefore, as a clinician, I want to ask myself, what can I do to help these challenging tooth movements express clinically? What do I need? Of course, I need anchorage, and that anchorage is going to come in the form of TADs. And so the TAD mechanics with aligners are much simpler than you can imagine. There's a buccal TAD and a lingual TAD. Now, sometimes we often don't place it in the same interproximal space. I would have preferred the mesial of the first molar, but it all depends where you have the space between the roots to place your TAD. Now, the intrusion is programmed into the aligner. The TADs offer us a point of anchorage, and the elastic that the patient wears from the buccal to the lingual over the TAD helps that posterior intrusion that's been programmed express itself clinically. So here we are at the end of treatment. We have successfully intruded the posterior section. We have created the posterior occlusal clearance that we need. Now we're going to retain the TADs, and the patient will wear a clear aligner type retainer and continue with the elastic at night to prevent hypereruption of the posterior segment until the restorative treatment is completed and the posterior occlusion is restored. Then we can remove the TADs. Now, if you're interested in reading about this case in detail, it is published in the Journal of Cosmetic Dentistry Winter 2020 edition, and I've wrote an article called Interdisciplinary Approach to Restorative Treatment with Clear Aligners. In there, we detail 3 different cases. The first case that you saw, another case where we use aligners to create an implant site for a missing upper lateral, and the third case is a class 3 anterior crossbite where we use aligners to correct the crossbite and prepare the teeth for veneer placement. The second case we're going to look at today is a case with anterior intrusion. Now this patient presents with a class 2 malocclusion with facial asymmetry, a canted maxillary-occlusal plane, and increased overjet. These are the intraoral photos. When we look at the cephalometric radiographs, we can see that this patient has a skeletal class 2 pattern. When you look at the condyle, the condylar necks are short, very typical of some of these open bite cases. So I have a diagnosis. My diagnosis, class 2 malocclusion with facial asymmetry. The maxillary-occlusal plane is canted down on the left. There's an increased overjet of 8 millimeters with minor crowding. And the cephalometric analysis shows a severe class 2 skeletal pattern with A and B 8 degrees, hyperdivergent SNMPs 49 degrees. Now, all of us here, including myself, would have offered this patient a surgical treatment plan. I think you need a double jaw surgery. We're going to do a maxillary impaction, mandibular advancement, and a genioplasty. But this patient declined the surgical treatment plan, and so we had to do a dental camouflage plan. This patient presents with a class 2 malocclusion with increased overjet, asymmetry, and a maxillary-occlusal plane that's canted down on the left side. On the right buccal occlusion, the canine is a full cusp class 2. On the left buccal, the molar is a half cusp class 2, but the canine is a full cusp class 2.
Looking from the overjet view, you can appreciate the amount of increased overjet of this malocclusion. The treatment plan involves extracting upper first premolars. As we played for the Clinchet plan, as the extraction spaces are closed, the incisors are being retracted and they're going to be intruded more on the upper left than on the upper right to correct the occlusion.
And so you see we have 36 aligners in this simple extraction plan. And how predictable is this going to be? Now when I use the superimposition tool, I can see that through the extraction of maxillary first molars, there's significant retraction of the incisors, which will help me reduce the overjet. And in the lower arch, we have maintained as closely as we can the same labiolingual position of the lower incisors. There's some anchorage loss in the upper arch, so you can see the upper second molars moving forward, and that's normal when we extract upper first premolars. But how about the occlusal cant? How about the anterior intrusion? When we look at the tooth movement assessment, these dots are colored blue, and the range of intrusion ranges from 2.58 to 3 for anterior intrusion, and they're two very difficult tooth movements. Now, even though the dots are not black, I'm asking myself, what can I do to help these challenging tooth movements express clinically? And is this cant skeletal or dental? Whenever a problem is skeletal, the degree of difficulty, of course, increases significantly. And in my mind, this was a skeletal occlusal cant. And to that regard, we placed TADs. Now, in the anterior, we just placed it unilaterally because the cant was down on the left. We put one on the buccal and on the lingual. You see buttons on the first molars to run class 2 elastics to help us control the anchorage. And if you look at the lower half of the screen, you can see a very simple biomechanics. You loop a TAD from the buccal to the lingual. The intrusion has been programmed into the digital software plan. The TADs are going to give us that point of anchorage, and the elastics will help that intrusion that's been programmed express itself clinically. So here we are at the end of 36 aligners, which is 9 months. And you can see that we've almost closed the extraction space. There's a minor midline discrepancy. We've got good overbite, and we've reduced the overjet. One more series of aligners. These are the post-treatment records. Pre- and post-treatment panoramic. Now this case was treated with vertical rectangular attachments before the days of G6 and before we had Smart Force aligner activations, but we controlled the vertical very well. You can see the roots are parallel across the extraction site. Looking at the pre- and post-treatment Ceph, we did some dental compensations for her, and the patient understood that. And then the cephalometric superimposition, which showed the significant incisor retraction, the loss of anchorage in the upper arch, and really good vertical control in the lower arch. And finally, of course, did we meet our treatment objectives? And we managed really to correct the maxillary occlusal cant with the help of aligners and TADs. Let's look at another one. In this case, we did a whole arch intrusion to treat excessive gingival display. The patient has a class 2 malocclusion with lower asymmetry, missing lateral incisors. And this is her malocclusion. I think she had previous orthodontic treatment. Clearly, she has canine substitution both in the upper as well as in the lower arch. Severe torque issues in the lower arch. There wasn't a bonded wire when she came into my office, but I suspect that could have been the result of an improperly made lower lingual retainer. These are the pre-treatment radiographs, and let's look at the tooth movement. This patient presents with a class 1 malocclusion with missing upper and lower lateral incisors. On the left side, the lower left posterior molars have been lost with resulting hypereruption of the opposing molars. The upper arch form is asymmetrical and squarish, and in the lower arch form you can also see an asymmetry with significant torque issues.
As we play through the ClinChat plan, there are 29 stages in the treatment, and it's just arch coordination and aligning and improving the buccal interdigitation of the teeth.
Now you don't see any intrusion program because this is a whole arch intrusion. If you get a digital treatment plan that comes back and every tooth in the arch is intruded, how many of us know that's never going to happen from a biomechanics point of view? You must keep some teeth level and intrude the others, or allow some teeth to extrude and the others to intrude. But in this case, the vertical movements were not programmed because we were planning a full arch intrusion with TADs. Now these are the TADs we use. Anteriorly, we use a 1.4 times 6 millimeter TAD, and posteriorly, we use a 1.6 times 8 millimeter TAD, and these are Ostem TADs. And then the patient very simply slings an elastic from the buccal to the lingual. And anteriorly, it depends if you want to change the torque of the incisors. Now, in this particular case, we wanted lingual root torque and labial crown torque. So we actually just made 2 precision cuts on the lingual and hooked up our elastic on the lingual that way. Now, if you had a normally inclined incisor, you don't want to do it this way, because when you do it this way, the crowns are going to move labial, your roots are going to move lingual. If you had a normally inclined incisor that you just want to intrude bodily, then you would place a lingual TAD for the anterior intrusion as well. Now remember, this patient only had 29 aligners in the initial treatment plan, and here she is 8 months into treatment, 29 aligners. If you plan your digital software plan efficiently, by the time you finish your first series aligners, 80% of your work really should have been done. And you can see here we've corrected the buccal occlusion to class 1. The midlines are coincident. The overbite overjet is normal. The torque issues, surprisingly, in the lower arch have actually been resolved. And here you can see that contrast and that comparison. And how are we doing with the smile? Beautifully. And I think when we give patients a different smile, sometimes they use the muscles of their face a little differently. And this is the smile the patient gave us. We're still going to continue some intrusion in the additional aligners, but for 29 aligners and 8 months, that's an amazing progress case. Now let's look at a class 2 case, posterior intrusion with TADs for correction of severe anterior open bite. Now this patient is only occluding on the first and second molars. Now these are different from the ones Dr. Moshiri showed because these are much more severe skeletal cases. This is a facial profile, very convex facial profile, class 2, huge open bite, huge overjet, and the upper arch actually is in crossbite. Is it dental or is it skeletal? Because the skeletal malocclusion is going to be much more difficult to treat. Look at the condyles on the panoramic. Again, the condylar necks are very short. The condyles look a little eroded. And when we measure out her cephalometric radiograph, her SNB is a standard deviation below normal. ANB is 7 degrees, and she's very hyperdivergent. Her SNMP is 53 degrees. Now, if I were to ask you, what would your skeletal treatment objectives be for this patient? I want to increase SNB, decrease ANB, and close down that mandibular plane angle if I could. So then my treatment plan or my treatment strategy would be to do posterior intrusion and allow the mandible to rotate upwards and forwards.
This patient presents with a severe skeletal class 2 pattern with anterior and buccal open bite. She is planned for a non-surgical, non-extraction treatment. We're going to close the open bite through sequential posterior intrusion as well as anterior extrusion. This will allow us to auto-rotate the mandible upwards and forwards as we rotate the occlusal plane in a clockwise direction. As we play through the ClinChat, you will notice that the pattern of attachments will change as the tooth that is to be intruded does not require an attachment, but the adjacent teeth require anchorage attachments. The amount of the intrusion is colored black on the tooth movement assessment, showing that this is an advanced tooth movement for clear aligners. To this regard, we plan to place posterior tabs to assist and augment the anchorage that's needed for this intrusion.
Now you notice several things. The first one is that there are no Class 2 mechanics programmed into this plan, even though the patient is Class 2. When the mandible auto-rotates upwards and forwards, I expect the Class 2 relationship to improve, but I don't know by how much. So the plan is to, number one, address the vertical, and then depending at the end of 40 aligners, how much Class 2 correction I've achieved, I can build some elastic wear or distalization into the next software plan. The sequence for posterior sequential intrusion and attachment design can be found in my textbook, Clear Aligner Technique, in the chapter on open bite treatment. So here she is at 6 months. Again, you know the road by now. Buccal tat, lingual tat, elastic over the tat. And here she is at 8 months. 40 aligners, 11 months. So let's look at the sequence. Initial, 6 months, 11 months. 90% of my work should be done. My molars are Class 1. Canines are still a bit Class 2. I'm very glad that I didn't build in any Class 2 treatment mechanics the first time around. And so from here on, we're going to make additional aligners. And sometimes you have an incredible case. You may not have completed treatment. Take a progress Ceph. Find out, how did this happen? What did I just do? And so we did some cephalometric superpositions. And in the global superposition, you can see that the mandible has auto-rotated upwards and forwards. In the maxilla, you can see some upper molar intrusion and retroclination, relative extrusion of the incisors. And in the lower, some very minor lower molar intrusion and some retroclination of the lower incisors. So that's how we got there. And when we look at the numbers, my A and B has decreased, my S and B has increased, and S and MP went from 50 degrees to 47 and closed down by 3 degrees. How did this happen? Well, in orthodontics, there's nothing new under the sun. In 1968, Dr. Kuhn talked about control of anterior vertical dimension with proper selection of extraoral anchorage. Now, he was talking about hypo headgears with posterior acrylic bite planes, but the principle remains the same. And in this publication, Dr. Kuhn says 1 millimeter of vertical movements of the molars results in 3 millimeters of the rotation of the mandible measured at Nathion. So don't think 1 millimeter of intrusion is insignificant. You're going to get a 3 millimeter change anteriorly. And of course, then the facial profile is going to improve. And this would have been the result if we had treated this case surgically. I think my treatment goals for her to treat her surgically would be to achieve this type of facial profile. Now, we got to this point right before the COVID pandemic. And then the patient moved back to Korea, so I'm very sorry to tell you that I cannot provide you with the post-treatment records. I'm still trying to contact her orthodontist in Korea to send them to me when he's completed treating the case. Now finally, our last case, Class 3 open bite treatment. And you can see that this case is ultimately much more severe. There's a negative overjet in addition to the open bite, moderate upper arch crowding, and minor lower arch crowding. In fact, this is more of a vertical problem because you can see that the patient has an increased lower face height. And these are the pre-treatment radiographs. Now, of course, this is a skeletal problem. And
this patient presents with a Class 3 malocclusion with anterior open bite and negative overjet. The entire maxilla is an anterior and posterior crossbite. There's moderate crowding in the upper as well as in the lower dental arches. When we look at the right buccal, she is only occluding on the second premolar, first and second molar on the right side, and on the first and second molars on the left side. In this first treatment plan, the maxillary premolars are extracted and the extraction spaces are closed. This increases the negative overjet in preparation for orthodontic surgery.
So, normal treatment plan. I approve the digital software plan. We ship the aligners to our office. On the day we were going to insert the aligners, patient walks in, extractions were not done, and she said, I have changed my mind. I don't want to have extractions and I don't want to have surgery. Dr. Tai, think harder for me. And sometimes it's patients that push us beyond our comfort zone. I'm used to doing things this way. I'm the doctor. This is the way it should be done. But until patients pull us down and said, we know you're a good doctor, go back to the drawing board, think harder for me. So I thought harder and I came up with a treatment plan. Now, those of you who look at the staging tab on the lower right side, you know that treatment plan is lower molar distalization. So now we're going to combine an AP correction protocol of lower molar sequential distalization, which will help me correct from class 3 to class 1. And then, no guesses, vertical protocol, anterior extrusion, you can see the optimized extrusive attachments, and posterior intrusion. Now this is very dangerous because when I posterior intrude, what will happen to the mandible? It's going to auto-rotate upwards and forwards. That's not going to help my class 3. So in this case, you can also see precision cuts for class 3 elastics.
This is the alternate treatment plan for a non-surgical, non-extraction treatment. The anterior open bite will be closed through the process of sequential posterior intrusion as well as a combination of anterior extrusion. You will note that the pattern of attachments will change on the posterior teeth as they are sequentially intruded and the anterior optimized extrusive attachments on both upper and lower incisors. There is a vertical bite jump leading to the final occlusion.
Now there are 62 aligners in this treatment plan for those of you sitting close enough to see that. And that's a very rare treatment plan for a Dr. Tai digital software plan. Usually my treatment plans are a lot more efficient, but it also gives you an indication of the degree of difficulty of this case. So here we go, 4 months. We have a buccal tad and a lingual tad, elastics from the buccal to the lingual. In the lower arch, you can see significant distalization spaces opening up. 10 months, holding my breath. 62 aligners, 15 months. The day she came into my office, my associate comes running into the private office. Dr. Tai, Sherry's here for our appointment. She's finished all her aligners. We're planning an additional aligner scan. You really want to go to chair 2 and take a look. And I just, oh no, I wonder what happened. I know this is the difficult case. I run out chair and here's her occlusion. These are the study models. You can see we've over-intruded the posterior now. There's a posterior open bite, premature anterior contact. So now we're going to back up a little bit, make some additional aligners, and we finish the case. Pre-treatment, post-treatment. We did a cephalometric superimposition. What happened? What did we do? How did we achieve this kind of treatment outcome? And here you can see the mandible did auto-rotate upwards a little bit. It looks like the entire upper arch was mesialized through wearing class 3 elastics. Not bodily distalization, some distal tipping of the molar, and then incisor retraction and retroclination of the incisor as we retract it, together with some pure extrusion to close the open bite. And her facial change. In fact, she said to me, Dr. Tai, many of my friends asked, did you get your surgery already? You look so different. And she didn't. So it has been an interesting morning. I do want to remind you, aligners are not a magic appliance. TADs are not a magic appliance. For those of you who are residents, oftentimes in the examination, when we ask a resident, how will you treat this case? They'll say, we'll use TADs, as though TADs is the magic answer that will magically pass you through the examination. But just a reminder that TADs are primarily used to augment anchorage, where certain tooth movements may be beyond the capability of aligners, or where an underlying skeletal discrepancy makes the malocclusion more challenging to treat. And so, what did we learn today? We learned to integrate TATS with aligner treatment, where additional anchorage requirements are required. We looked at correcting a maxillary-occlusal cant, among other things, and combining AP protocols with vertical protocols to correct open bites in Class 2 and Class 3 malocclusions. And so, I wish you every success in advancing the limits of aligner treatment with TATS. Let us dream the impossible dream together. Thank you very much.